Okay, so let's look a bit more at type 2 diabetes. So in the image, don't worry about what's happening within the cell. We don't need to go over that. Let's look at what's happening in the bloodstream first. So there's lots of glucose molecules and, oh, there's lots of insulin, right? So what's the problem? Well, the problem is that the cells have become resistant to the insulin and those protein channels won't open. So the glucose has no way of getting into muscle cells or fat cells, and they become hyperglycemic, right? And that's why we call it cellular resistance to insulin, which leads to hyperglycemia. Now, there's not going to be any diabetic ketoacidosis since the insulin is going to all the fat cells in the body and saying, there's no need for you to break down. I have lots of energy in the form of glucose in my bloodstream. Okay? So it's a very different disease compared to type 1 diabetes. You don't get diabetic ketoacidosis. Okay? There's no fat or protein breakdown or acidosis, actually. Okay? Because the insulin is able to communicate with all these different cells and say, no, I'm okay. I'm just having difficulty getting glucose into the cells. But you don't need to break down your fats. You don't need to break down your proteins. And oh, by the way, the liver, you can still continue to make glycogen. Okay? So type 2 diabetes usually has a gradual onset. As the cells of the body become more resistant to insulin, the serum glucose gradually goes up and up and up. And it can be over the span of months to years, right? In fact, there's millions of people out there that have no idea they have type 2 diabetes. But I can guarantee you there's no one out there that will go on for months and not know that they have type 1 diabetes because you get so ill from diabetic ketoacidosis that you have to go to a hospital or you will die, okay? So the beta cells in the pancreas are working just fine still. They are secreting insulin. The problem is that the body cells all around, say the fat, the muscle, all the cells are saying, you know what, I'm not going to respond to the insulin and open up my glucose channels, okay, leading to elevated serum glucose, hyperglycemia, okay? So really, the main issue with type 2 diabetes is hyperglycemia leading to damage of many organs in the body, right? And the number one cause of insulin resistance is obesity. Okay. So the fat cells are able to release chemicals and mediators that make the receptors resistant to insulin. Okay. DKA is almost unheard of in type 2 diabetes due to the fact that the insulin is still able to tell the fat cells, please don't break down your fatty acids. I don't need you to break them down. Okay. So when we do blood tests, if we wanted to do a serum insulin test on a type 2 diabetic, it would often be elevated. Okay, so there's more than enough insulin typically in type 2 diabetes. And we actually call it a state of hyperinsulinemia, so elevated insulin levels in the blood. So what can be done for type 2 diabetes? Well, type 1 we mentioned. Treatment? Sure. Get a good diet, do some exercise, insulin. You need insulin, lifelong. Type 2 diabetes, okay, diet, exercise, and weight loss, really important to try and help those cells become sensitive to insulin again. And we can use oral medications, and some of the oral medications stimulate the pancreas to secrete more insulin, and some of the oral medications um, work at uh, the cellular level, sorry, to make the cells less resistant to the insulin. Okay, we can't use oral medications in type 1 diabetes because there's no insulin um, to to secrete from the pancreas. So we can't force medications to make the pancreas secrete insulin. There isn't any. And there would be no sense in using a medication that makes the cells more sensitive to insulin if there's none around. Okay? And lastly, in type 2 diabetes, we can use insulin as part of the treatment, right? So if we find that diet, exercise, weight loss, and oral medications isn't enough to control serum glucose, we can add insulin injections as part of the treatment to control their serum glucose levels. Okay, so let's talk about a complication of type 2 diabetes, hyperosmolar hyperglycemic state. Okay, don't worry about this long term. So we'll just call it HHS. Okay, so what happens? Well, there's enough insulin in the bloodstream, but again, it's that cellular resistance, right, to the insulin. So what can happen if, say, someone gets ill, say they get a pneumonia, or they get an infection, a urine infection. Well, infections can make the insulin receptors even more resistant. So they get higher and higher serum glucose levels. So in a normal person, when you get sick, your insulin receptors are doing just fine. They can still bind insulin and they can allow glucose into the cells. In type 2 diabetes, an illness can cause those receptors to be more resistant, leading to higher serum glucose levels. Okay, so as the glucose goes higher and higher and higher, say 500, 600, 700, your blood is filled with glucose, and it's just going to have this massive diuretic effect where you're losing lots of sugar out through your urine. You're taking fluid with it, so you have polyuria. You're getting really dehydrated because you're losing so much fluid with the glucose in your urine. You're drinking a lot because you're so thirsty. Okay, so it's an extreme form of hyperglycemia. By the way, you're not going to see that they became acidotic because they have enough insulin to stop the fat cells from breaking down fatty acids. Okay, so these people get profoundly dehydrated because of all the loss of fluid with the sugar in the kidneys. In fact, the blood can get so viscous and thick because of the severe dehydration and the increased osmolarity in the blood. Okay, so you can imagine that these people want to drink tremendous amounts of fluid. Okay, and typically when we do tests, okay, in this condition, that's a complication of type 2 diabetes, their blood glucose is really, really high, but they don't have any ketones. They're not acidotic because the insulin is stopping the breakdown of the fatty acids. It's stopping the breakdown of protein. It's purely a high sugar problem in the bloodstream, and they become severely dehydrated. Okay, so what are other causes of diabetes? Well, we mentioned gestational diabetes, where we think from the weight gain, you develop a type of insulin resistance, just like type 2 diabetes, and your serum glucose starts to climb. Okay? What do we do for women that develop gestational diabetes, well, we start them on insulin, right? We don't put them on pills. Some of the pills are not safe in pregnancy, so we just give them insulin during their pregnancy. And after the pregnancy, after they've delivered, the glucose levels typically return to normal and they don't need insulin any longer. This is definitely a risk factor. The fact that you had gestational diabetes is a risk factor for developing type 2 diabetes later in life for sure. Okay? What about secondary causes of diabetes? Well, cortisol. So if you have excessive cortisol, for example, I put someone on prednisone or dexamethasone or some kind of cortisol, well, that's going to make the liver break down glycogen to glucose, and they're going to have, we can cause diabetes from excessive cortisol administration, or if they have Cushing's disease from, say, an adrenal tumor, okay, they can get secondary diabetes. Hyperthyroidism. Well, hyperthyroidism is an excessive hypermetabolic condition, and they often have secondary diabetes, high sugar in the bloodstream. Okay. What about someone who has recurrent pancreatitis? So you can get pancreatitis from excessive alcohol consumption. You can get pancreatitis from a number of medical conditions. So not that they're that important right now. I would think of alcohol as the most common cause of pancreatitis. But if someone has a very elevated lipid profile or triglycerides, well, triglycerides irritate the pancreas and lead to pancreatitis. Another cause, just for your interest, is if you have a gallstone that blocks the pancreatic duct and all of its digestive juices can't get out into the small intestine, that can cause intense pancreatitis. Okay, so now you know the three most common causes of pancreatitis: alcoholism, hypertriglyceridemia, and gallstone pancreatitis. Anyways, recurrent damage of the pancreas will lead to diabetes because it's destroying the beta cells and it's gradually lowering insulin levels. Okay? Cystic fibrosis. So that's a condition in the lungs where you have excessive mucus secretion, recurrent pneumonias, recurrent bronchitis, but it also blocks the ducts in the pancreas, and it can lead to pancreatic insufficiency. So they don't have pancreatic enzymes to break down food, so that they'll have malabsorption problems. But at the same time, cystic fibrosis will finally harm the beta cells and reduce insulin production. Okay. What about drugs? So we mentioned corticosteroids for sure. They can cause diabetes, or they can, at least at a minimum, cause hyperglycemia in your bloodstream. There's some antipsychotic medications, some of the newer ones you may have learned, such as olanzapine, risperidone. Well, they cause people to gain weight. And when you gain weight, you can develop type 2 diabetes, right? So what else on this slide? Well, TPN can cause diabetes while you're on it, just from the very fact that TPN, you may be getting, so total parental nutrition is where we're feeding someone that's not able to use their gastrointestinal tract, right? So we put an IV in, and we're actually feeding them a product that has carbohydrates, proteins, and fats within it. So it's replacing their gastrointestinal tract and the food that they can't eat due to whatever illness they have. And that can lead to hyperglycemia because it's not the same as eating food that goes through the gastrointestinal tract. Okay, so we're almost there. Just a couple of slides left. So chronic complications of having diabetes, whether it's type 1 diabetes or type 2 diabetes, um, these complications can occur in either one of them. Okay, so diabetes and hyperglycemia lead to small arterial damage and large arterial damage in the body. Okay, so microvascular disease, small vessels, and macrovascular disease, larger arteries. So we'll divide it that way and talk about each one. So let's talk about the microvascular vessels, so the capillaries. Well, they lead to atherosclerosis. So diabetes leads to plaque formation and blockages in blood vessels. So if it's in your eye, say the back of your eye, retinal damage, it can lead to arterial blockages causing blindness. It damages the blood vessels, so it can lead to hemorrhages of the blood vessels. And it also leads to little aneurysms where the vessel, the little capillaries, the vessels become weak and they have outpouchings called aneurysms. Okay, so I always think of diabetes as causing accelerated injury to any vascular bed. So microvascular, okay, the little blood vessels in your retina leading to blindness, nerve damage to peripheral nerves, say in your feet. Well, those little nerves need blood vessels and capillaries to feed them. So as the capillaries get blocked, you start to get nerve damage in your feet, your toes, your legs, and that leads to numbness, loss of sensation, and pain, right? So that's what's called diabetic neuropathy. Okay. Same thing happens in your kidney, sorry, where the tiny capillaries that are perfusing through the kidney and going to the nephrons are getting blocked and damaged from the high sugar levels that's damaging the vessel walls, and that leads to loss of nephrons, right? Because the nephrons needed a blood supply and the capillaries are slowly getting blocked. That leads to loss of nephrons and gradually chronic renal failure. Okay. What about the larger arteries? So you can have larger arteries to your legs blocked, where you can start to lose toes or your foot or your leg because of peripheral arterial disease, right? So some of the larger arteries are affected by diabetes, and it's one of the common causes of having to have toe or foot or leg amputations is diabetes. Heart disease. Well, the diabetes leads to blockages and damage of the coronary arteries that feed the heart, and they develop atherosclerosis in the coronary arteries, and that leads to blockages of the arteries that then leads to angina and heart attacks. Okay. What about in the brain? So blocked cerebral arteries due to atherosclerosis again. And as the atherosclerosis progresses and an artery gets blocked, that will lead to a stroke. Okay, so really think of the complications of diabetes as, okay, what's happening with all these blocked arteries and vessels, because that's what's going to, in the end, cause all these chronic complications of blindness, nerve damage to the legs, renal failure, amputation of toes, feet, or leg, heart disease, strokes. It's all from hyperglycemia leading to atherosclerosis within the arteries. Okay. Um, so always keep in mind, diabetic complications are often related to um, damaged blood supply to the area. Okay, so when I think of the brain, I think of stroke because of blocked arteries. I think of the eye, I think of blocked arteries to the retina. I think of the heart, blocked arteries in the coronary vessels. Um, Peripheral vascular disease down a leg, that's a blocked artery in one of the bigger arteries, such as the femoral artery. Or maybe it's blockages in tiny capillaries in the toes and the feet. Okay? So always think of the atherosclerosis that's leading to blocked arteries as a complication of diabetes. Okay, so here's a nice image, just again summarizing that for you. What's happening in the eye, right? So high serum glucose is causing the little tiny vessels at the back of the eye to get blocked, and that leads to retinal injury, leading to blindness. Kidney. Well, diabetes, the high sugar of diabetes leads to small vessel disease, the capillaries, and they get blocked, the nephrons die. That causes hypertension in the system because now the kidneys are not being able to filter the fluid, the blood as well. So on top of the diabetes, now you have hypertension caused by the diabetes, and that's going to injure the kidneys even more. Okay, the neuropathy that we spoke about, because of the blocked little blood vessels that are feeding the little tiny nerves in your toes, your feet, and your legs, and people get peripheral neuropathy, and that can be in the form of sensory loss. They can't even feel their feet anymore, which is a huge problem, because if you can't feel your feet, you don't know if you're stepping on a nail, or if you don't know if you're standing on something very sharp, right? It can lead to painful legs as the neuropathy. Okay. The brain, well, arterial blockage from atherosclerosis causing strokes, and if it's not a stroke, it could be a transient ischemic attack, which is a little blockage occurred, but the body was able to open it back up quickly. Okay. The heart, well, remember, diabetes leads to hypertension in the kidney because the kidneys are gradually being injured by the diabetes. The hypertension is going to make the heart work harder, and on top of that, the coronary arteries, they are becoming atherosclerotic and forming plaques because of the diabetes as well. Okay? And lastly, the peripheral arterial disease, again, blocked blood vessels, right? Reduced blood flow to the leg. And that's going to result in, if you have poor blood flow down your leg, well, you're at risk for ulcers that don't heal. You're at risk for infections that heal very poorly. And if you start to get leg ulcers because of lack of blood supply and they get infected, well, that can be very hard to treat, right? And sometimes people need amputation because of that. Okay, so here's just some images of skin ulcers, skin breakdown, loss of sensation, leg infections, and finally amputation. And all of these are reduced to poor blood supply going down the leg and feeding all the tissues of the foot and leg. And if you have poor blood supply, you're very prone to getting skin breakdown and ulcers. Okay. Now, some of this may have been caused from also the diabetes causing a neuropathy, so lack of sensation to the legs. And if you can't feel your legs, you don't know what you're standing on. And that leads to skin breakdown. We're constantly moving our feet to avoid any skin breakdown. And normally we would definitely notice if we were standing on something sharp in our shoe. Whereas a diabetic that's lost sensation can't sense that. So they're very prone to skin ulcers, skin breakdown, and really poor wound healing. Okay, so that's the end of this module. I hope you got lots out of it. I think between the PowerPoints with the voiceover and your textbook, this information will really help get consolidated for you. And then the case studies are in addition to try and get you prepared for bringing all the information together. Okay, so if there's questions, bring them to tutorials, bring them to your instructors. Make sure that you understand the information so that you can bring concepts together in case studies and also going forward in other semesters and also when you're working. Okay? See you at the next module.